Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, I'm covering part 2 of burns. If you haven't watched part 1 already, go watch that one first, so this part will make more sense, okay? So this is part 2 of burns, and I noticed in the comment section, you guys are always asking which book I'm teaching from, and I teach from several books, depending on the subject matter. So when it comes to burns, this is actually the book that I'm teaching out of. So this is the title. It's 8th edition, and here's the author. There you go. Okay, so this is the book I'm teaching out of. Let's get started. Now, where I left off for part 2 burns is there we go, is the resuscitation phase. Let me make this bigger for you. All right, the resuscitation phase of burn injury. Remember in part 1, we talked about, I talked about in burns, how that patient is extremely dehydrated because all of the fluid, the protein that was in the vascular space has left the vascular space and gone into the interstitial space, okay? So now the resuscitation phase of burn injury. So immediate care focuses on maintaining open airway, because who cares about anything else if that patient's not breathing? Open airway, ensuring adequate breathing and circulation, limiting the extent of the injury, and maintaining the function of vital organs. Because remember what happens, guys, when all of the fluid, the vitamins, the minerals, the nutrients, oxygen left that vascular space, those organs were not being perfused, okay? That's number 1. Number 2, if that patient had burn, we're concerned about them breathing in that smoke and those noxious agents that can cause, edema, right? And that can include the patient's airway. So we got to make sure we're taking care of all of this. The resuscitation phase, look at this, what it says. It's the first phase of a burn injury. It begins at the onset of injury and continues for 24 to 48 hours. During this phase, injuries evaluated and immediate problems of, and then look at this, guys, this is the second time we're seeing this in just the second paragraph, fluid imbalance. Why fluid imbalance? Remember, the potassium is what? Increased. Sodium is what? Decreased. There's a fluid shift. All those vitamins and nutrients is out of order. So the patient's going to have fluid imbalance, edema. Why? All of that fluid that was in the vascular space has gone to the interstitial space. So that patient's going to look very swollen. Okay. And reduced blood flow are assessed. Of course, reduced blood flow, because all of the fluid that was in the vascular space that's supposed to be going to the organs to perfuse the organs are gone because they went into the interstitial space, because all of these are problems that are happening with the burn patient. What is going to be our concern? Again, number 1, secure the airway. Make sure there's no obstruction of the airway, that patient's actually able to breathe. 2, support circulation and organ perfusion. All of the fluid, electrolytes, minerals, oxygen that's carried in the blood that left the vascular space, how are those organs going to be perfused? So we have to make sure that we get perfusion for the patient's organs. By what? Fluid replacement. Let me stop there for a minute. When it comes to burns, remember the patient is going to be at risk for very high dehydration. We're going to have to replace that fluid. What is the number 1 type of fluid that we give the patient when they have burns? Lactate ringers. Because that lactate ringers has the closest consistency to the blood. So that's what we give to that patient when it's a burn patient, lactate ringers. If we don't have it, we may use, we'll use normal saline. But when it comes to burns, as a student, I want this to be stuck in your mind, lactate ringers, okay? So anyway, where were you? Right here, fluid replacement, that's the lactate ringers. Let me get my nails done. Support circulation. Okay, we did that. Keep the patient comfortable with analgesics. Remember, I talked to you about this in part 1. Pain never killed anyone except for certain situations, such as stones, kidney stones, gallbladder stones, right? Stones, cancer treatment patients, MI, sickle cell, and burns. The burn patient, they're not going to be on, Motrin or acetaminophen. No, they're going to be on opioids. They're going to be on narcotics, because burn pain is like one of the worst pains you can ever experience. And that pain is so severe, it can affect your physiological status. Absolutely. So yes, we have to make sure the patient is comfortable with analgesics. We want to prevent infection. I talked to you about that in part 1. And maintain the body temperature and provide environmental support. You see all of these, 1, 2, 3, 4, and 5. This has been seen on NCLEX many times as a select all that applies. Don't say I didn't warn you, make sure you know it. Moving on. Guys, by the way, thank you for the words of encouragement. I read all of those comments, and it's so helpful for me, excuse me, and encourages me to keep going when I see those comments that I'm helping you. Thank you. And if there's something that you'd like to see me cover, go ahead, put in the comment section, because I am making a list of videos that you guys are saying that you would like, so I can make them for you. All right, let's talk about emergency management of burns. General management of all types of burns. Number 1, assess for airway patency. We don't care about anything else if that patient's not breathing. So we need to make sure that they have an unobstructed airway, number 1, before anything else. What else? We need to administer oxygen as needed. We're going to cover the patient with a blanket. Why? Shock. Shock. I talked to you guys about that in part 1. We're going to keep the patient NPO. Why? Because we never know. We might have to take that patient to surgery, and when the patient goes to surgery, they have to be NPO. So we're going to keep them NPO. We're going to elevate the extremities. Remember, shock, guys. We want to bring blood flow back to the heart. We're going to elevate extremities if no fractures are obvious. Obviously, guys, if we suspect the patient has a hip fracture or a limb fracture, we're not going to do that. But because of the shock, we're going to want to make sure we elevate those extremities. We want to make sure we keep them warm. And we definitely are going to be replacing fluids, giving them fluid replacement. Let's keep going. Like this. Obtain vital signs. Initiate an IV line and begin fluid replacement, again, because of the shock. And let me tell you something, we're going to be giving them fluids fast and hard, because this patient is extremely, extremely dehydrated, and they're at risk for those organs shutting down on them. So we have to perfuse them. And the way we perfuse them is by giving them fluid replacement. What type of fluids? Lactate ringers, okay? Administer tetanus toxoid for prophylaxis. We're going to perform head-to-toe assessment. Let's talk about chemical burns. What if the patient had a chemical burn? My camera won't let me breathe. Here we go. So chemical burns. If dry chemicals are present on the skin or clothing, look at this, don't wet them. If the chemical's dry, you're going to dust it off. Do not wet them. You're going to brush off any dry chemicals present on the skin or clothing. Remove that patient's clothing. Do not attempt to neutralize the chemical unless it's been positively identified and the appropriate neutralizing agent is available. So don't be trying to play chemist. Don't try to use something else to neutralize that chemical unless you know for sure what type of chemical it is, and you know for sure that whatever that neutralizing agent is actually a neutralizing agent for that chemical. And usually we don't know. So you're going to teach a patient not to do that. Electrical burns. At the scene, separate the patient from the electrical current, of course. Why would you be trying to care for that patient when whatever's killing them is still killing them? So you're going to remove them from that current. You're going to smother any flames that are present, initiate CPR immediately, and obtain an ECG, because we know with electrical burns, the patient's at high risk for these cardiac dysrhythmias. Radiation burns. You're going to remove the patient from the source of the radiation. If they have been exposed to radiation from if the patient has been exposed to radiation from an unsealed source, remove his or her clothing. Here's the key, guys. Here's the key. By using what? Tongs or lead protective gloves, not your hands. That's the key. Using tongs or lead protective gloves, never your bare hands. If the patient has radioactive particles on the skin, send him or her to the nearest designated radiation decontamination center and help the patient bathe or shower. Okay, let's talk about collaborative care, respiratory assessment. Let's look at what this says. It says inspect the mouth, nose, and pharynx. Burns on the lips, face, ears, neck, eyelids, eyebrows, and eyelashes are strong indicators that inhalation injury has been present. Hello, that's why if the patient has any of those type of burns, that's considered what? A major burn. Because if they have burns on their lips, their face, their nose, how are you going to have burns in that area and not have breathed in those noxious agents, including the smoke? How? It's not possible. That's why if they have those type of burns, that's considered what? A major burn. And we talked about the difference in burns in part 1. Make sure you guys catch that. Okay, let's keep going. It says burns inside the mouth and singed nasal hairs also indicate possible inhalation injury. Whenever you suspect that patient has breathed in that smoke, those noxious agents, we're going to be concerned about swelling, edema, obstruction of the airway. Let's keep going. It says black particles of carbon in the nose, mouth, and sputum, edema of the nasal septum, and smoky smell of the patient's breath indicates smoke inhalation. All of those are beautiful select all that applies for when the nurse would suspect smoke inhalation. All of those are your signs and symptoms that you should suspect that that patient breathed in the smoke. So if you guys are studying this for a test, you better know them, all of them, okay? Factors determining inhalation of airway obstruction, and I said no with 3 exclamation marks. Factors determining inhalation or airway obstruction. Didn't I tell you whenever you're studying and you see information in text, then you see that information being repeated in text or in a box, table, diagram, illustration. That means it's going to be a test question. That's important for you to know. Didn't they just tell us these signs and symptoms, hold on a second, of smoke inhalation down here, right? They gave us all of these signs and symptoms, but on the very next page, the author found it appropriate to give it to us again. That means it's important for you guys to know. Any patient that was injured in a closed space, and that makes sense. Let's say there was a fire out in the open, right? There's still a chance for them to breathe fresh air and oxygen. But if it was in a closed space, they're going to have breathed in that smoke. Patients with extensive burns to the face, that's another sign and symptom that they breathed in that stroke. Smoke, they breathe in that smoke. And remember, guys, when it comes to smoke inhalation, what happens is that smoke is so toxic, it's so noxious to the tissues, that patient's airway may start swelling up and the airway becomes obstructed and they can't breathe. Intraoral charcoal, especially on teeth and gums, patients who are unconscious at the time of injury. So there's smoke, but they were unconscious, so it's not like they could have got up and ran away. Patients with singed hair, nasal hairs, eyelids, eyelashes. Patients who are coughing up carbonaceous sputum. Changes in the voice, such as hoarseness or brassy cough. That's another test question. Use of accessory muscles or stridor. That's another test question. Poor oxygenation or ventilation, Edema, erythema, that's the redness and ulceration of the airway mucosa. You better suspect that their airway is about to close up on them. Wheezing, bronchospasms. These look like beautiful select all that applies to me if I were a nursing instructor making a test for you. You better know these. Let's keep going. A change in respiratory pattern may indicate pulmonary injury. The patient may. Here are the signs and symptoms. This is like the third time we're seeing this, guys. Signs and symptoms that the patient has breathed in that smoke that obviously can affect the airway. What are they? Their voice becomes progressively hoarse. Didn't we see this up here somewhere? Now we're seeing this again here, and I think we saw it on the other page. They develop a brassy cough. They have difficulty swallowing, that dysphagia. They produce sounds on exhalation that include audible wheezing. Let me tell you something, guys. Wheezing is the sound of air trying to get through an obstructive airway. That's what wheezing is, the sound of air trying to push through some type of obstruction. Okay, so hearing audible wheezing, crowing, and stridor. Stridor is a medical emergency. Let me tell you something. If you hear this, you hear wheezing, or you hear stridor, right? Then all of a sudden, you don't hear it anymore. Does that mean the patient miraculously got better? No, that means that the airway is completely obstructed. That's why you're not hearing any sound. Because no, wheezing, yes, wheezing is not good. Yes, obstruction is not good. But guess what's even worse? When it suddenly stops. So that wheezing, that stridor, you're hearing air trying to push through an obstructed airway, then all of a sudden it stopped. The reason it stopped is because that airway got obstructed completely and the air can't get through. Okay. Critical rescue. For a burn patient in the resuscitation phase who is hoarse. I'm sorry, guys. I'm filming in my office because my studio is being redone. So excuse the phone call. Why are you guys trying to reach me at, what time is that? 9:30 at night. No one's there. No one's picking up. All right. Anyway, for a patient in the resuscitation phase who is hoarse, has a brassy cough, drools or difficulty swallowing, or produces an audible breath sound on exhalation, immediately apply oxygen and then notify the rapid response team. Let's talk about this. Let's go back. For a burn patient that's in the resuscitation phase, their voice is hoarse. They have brassy cough, drools or difficulty swallowing, or produces audible breath sound on exhalation. All of those are signs and symptoms that they breathe in those noxious agents, and what's happening? Their throat is closing up on them. What are you going to do? Number one, give them oxygen, then notify rapid response. Okay? Patients with severe inhalation injuries may have such rapid obstruction that within a short time, they cannot force air through the narrowed airways. As a result, the wheezing sounds disappear. Ladies and gentlemen, is that a good thing when the wheezing sound disappears? No. This finding indicates impending airway obstruction and demands immediate intubation. Their airway is closing up on them. That is on NCLEX. You need to know that. You need to prove that you are a good nurse and you understand that this is a medical emergency and that patient needs to be intubated immediately, okay? Many patients are intubated when an inhalation injury is first, look at this, suspected. All we have to do is suspect that you breathe in those noxious agents, and we're going to go ahead and intubate you. We're not taking any chances. Many patients are intubated when inhalation injury is first suspected rather than waiting until the obstruction takes place. That is how emergent this is if a patient has breathed in those noxious agents. Okay, that airway obstruction can happen very fast and the patient can die. You don't want that to happen on your watch. Heat damage of the pharynx is often severe enough to produce edema and upper airway obstruction, especially epiglottitis. The problem can occur anytime during the resuscitation phase. In the unresuscitated patient, supraglottic edema may be delayed because of the dehydration that occurs with hypovolemia. Let's talk about this. Remember, guys, during the resuscitation phase, all of the fluid, the protein that was out in the interstitial space is coming back to the vascular space. Okay, so look what it says right here. In the unresuscitated patient, the supraglottic edema may be delayed. Why? Because if that patient has not been resuscitated yet, all of that fluid is still staying where? In that interstitial area. It has not gone back to the vessels. Okay, so look at what it says, because of the dehydration that occurs with hypovolemia. But during that resuscitation phase, we better be very concerned with edema of the airway. During fluid resuscitation, however, the tissues rehydrate and they swell. Remember, guys, that patient that was going through excessive dehydration, we have to rehydrate them. We have to give them the fluids. What are we giving them? Lactate ringers. When it's known that the upper airways are exposed to heat, intubation may be performed as an early intervention before obstruction occurs. Didn't they just tell us the same thing up here? Take a look. Didn't they tell us that if we suspect they breathed in smoke and those noxious agents, we're going to intubate them? They said it here, and then they tell you a second time down here. Why? Because it's so important. You're most likely going to see that on a test. You need to know it. Let's keep going. Nursing safety priority. When intubation has not been performed on a patient whose upper airways were exposed to heat or toxic gases, you have to continually assess upper airway to recognize the signs of edema and obstruction. What are those signs? The wheezing, the brassy cough, the dysphagia, the hoarseness, all of these right here. If that patient hasn't been intubated, but we even suspect that they've had inhalation of those toxic gases, but they're not intubated, we're going to be watching out for those signs and symptoms. We see any of those, that patient's going to be intubated immediately. Nursing priority alert, critical rescue. When manifestations of pulmonary edema are present, again, the wheezing, the stridor, the brassy voice, the hoarseness, the difficulty breathing, the dysphagia, difficulty swallowing, the drooling, all of those signs and symptoms of edema, right? When those signs and symptoms of pulmonary edema are present, you're going to, one, elevate the head of the bed. Why? Whenever patient's having difficulty breathing, just elevating that head of the bed, what happens is it helps the patient's lungs expand. Why? Gravity's helping. Okay, so you know how this is your diaphragm and your lungs are right over the diaphragm. You take a deep breath in, the diaphragm goes down so more oxygen can come in. Then you take a deep breath out, diaphragm pushes back up. Deep breath in, diaphragm goes down, deep breath out, it pops back up, right? So when you elevate the head of the bed, gravity helps when that patient tries to breathe for the diaphragm to drop so the lungs can expand. Patient has difficulty breathing, what's the first thing you do? Elevate the head of the bed to help them breathe. So you're going to elevate the head of the bed at least 45 degrees. Next, you're going to apply oxygen. Third, you're going to call the rapid response team. Skin assessment. So you're going to assess the skin to determine the size and depth of the burn injury. The size of the injury is first estimated in comparison with the total body surface area. For example, a burn that involves 40% of the TBSA is a 40% burn. Okay, so a burn that involves 50% of the total body surface area, that's a 50% burn. Okay. GI assessment. We talked about this in part one. Paralytic ileus. If you haven't watched part 1, go watch it and you'll understand why the patient will have paralytic ileus. Require NG tube inserted to prevent aspiration and remove gastric secretions. I want you to think about it. While peristalsis has stopped because the GI tract is not being perfused, guess what? That stomach is still making hydrochloric acid. And if there's nothing in the stomach for that hydrochloric acid to eat on, what's it going to do? Eat on its own stomach lining, right? And the patient's going to end up getting ulcers. So you better believe that patient's going to have an NG tube. They're going to be NPO and they're going to have an NG tube in place. Burn assessment during resuscitation phase. And you see, I said you better know with 3 exclamation marks, so you know it's important. Let's talk about the serum studies first, okay? We're right here. What is important to know about the serum studies? Let me make it smaller so you can see. Okay. There we go. So, serum studies. Hemoglobin is going to be elevated as a result of fluid volume loss. Remember, when the patient has a burn, all of the fluid leaves that vascular space and it goes to the interstitial space. So what happens is we're going to see the H&H increase. Whenever a patient's going through dehydration, the H&H is going to be up. And we know that any burn patient is at high risk for dehydration. So we're going to see the hematocrit go up because of the fluid loss. And we're going to see the hemoglobin go up because of the fluid loss. What did I write here? When increased, yes. So when the H&H is increased, that means dehydration. You need to know that. What about the urea nitrogen? That is going to be elevated because of the fluid loss. Whenever something severe is happening to the body, such as a burn where that patient is severely dehydrated and possibly can go through shock, what do you think the kidneys are going to do? They're going to shut down. The kidneys are going to try to hold on to as many fluid, vitamin, nutrients as it possibly can. So we're going to see that BUN and creatinine go up while we see the urine output go down. Okay, so yes, we're going to see the urea nitrogen elevated. What about glucose? We're going to see the glucose elevated. That's as a result of the stress response and altered uptake across injured tissues. You guys know that whenever your body's stressed, psychologically, emotionally, physically, your glucose goes up. Why? You need that energy to fight the infection and all the stress from the burn, or flight, right? Fight or flight. So you expect that glucose to go up. Let's talk about electrolytes. We talked about this in part 1, very in depth. Sodium's going to be down. Sodium is trapped in edema fluid and lost through the plasma leakage. Remember, plasma, that's the protein portion of the blood. So the sodium's going to be down while potassium is up. Remember that potassium's increased because those cells are releasing all that potassium. So the potassium's elevated as a result of disruption of the sodium-potassium pump. And you guys know the sodium and potassium go the opposite ways. So if sodium's going down, you know the potassium's going to be up. Tissue destruction, as those tissues are destroyed, those cells release potassium. And red blood cell hemolysis. So you need to know during burns, the potassium is up and the sodium is down. Let's talk about arterial blood gases. What are those going to look like? By the way, guys, you do need to know the number. So you need to know the normal value of your hemoglobin, your hematocrit, your urine nitrogen, your glucose, your sodium, your potassium, all of them. You need to know those numbers. Do index cards, okay? Arterial blood gases. Now, the partial pressure of oxygen is 80 to 100. Do not confuse that with oxygen saturation. The oxygen saturation, you want to be, that's your O2 sat, you want it to be 95 to 100. 95. You want it to be 98 to 100. We'll take 95, but really we want it to be 98 to 100. The oxygen saturation is not the same thing as partial pressure of oxygen. So the PaO2, 80 to 100, that is our normal range. That is going to be slightly decreased. Partial pressure of carbon dioxide, you know the range 35 to 45, that's going to be slightly increased. Why? Because of the respiratory injury. You know, when the lungs, let me show you something. When you're breathing, guys, you're going like this. You're breathing oxygen in and you breathe out what? Carbon dioxide. So it makes sense. If those lungs are not working properly, patients not going to breathe out that carbon dioxide like they're supposed to. So it stays in the body. And so we're going to see what? That it's going to be increased. We're going to see acidosis. The pH is 7.35 to 7.45. Anything less than 7.35, patient's going to be acidic. Anything more than 7.45, they're going to be more basic, alkalinic. So what happens with the pH? Take a look. It's going to be low, which means the patient's going to be acidic. Low as a result of the metabolic acidosis. Carboxyhemoglobin, 0 to 10%, that's going to be elevated because the patient was breathing in carbon monoxide. It makes sense. Assessment, possible nursing diagnosis for that patient who is a burn patient. 1, potential for inadequate oxygenation. Absolutely. 2, potential for shock because of all the fluid that left the vascular space and the organs can't be perfused. 3, potential for organ ischemia. Of course, if those organs are not being perfused, what do you think is going to happen? Those tissues are going to start to die off. 4, pain. I'm telling you guys, pain never killed anyone except for specific situations, and burns is one of them. You have to address pain. You have to treat pain as you would any other physiological status. That patient is going to get narcotic opioids. Potential for respiratory distress. Absolutely. Airway maintenance, that's our #1 priority. If that patient's not breathing, we don't care about anything else. Oh, I missed something on this table. Let me scroll up really quickly. I missed the last part. For total protein, the total protein is going to be low. Why? Remember, the albumin part of the blood, which is a protein, left that vascular space. Their protein is going to be low. So when we're caring for that burn patient, one of the things that we have to give them is a high protein diet. And protein's also good for what, guys? Wound healing. Not only vitamin C and protein is good for wound healing. That protein is going to be low. We're going to have to replace the protein. And albumin, again, albumin is a part of the blood, but it's what? Protein. So yes, it's going to be low. Why? Lost through urine. So you guys need to know that. Remember that upper airway edema becomes pronounced 8 to 12 hours after the beginning of fluid resuscitation. So that patient's severely dehydrated, we're worried about shock, we're worried about those organs failing on them. So remember, we're giving them fluids hard and fast. About 8 to 12 hours after us giving them the fluid hard and fast, that's when the chances of upper airway edema can occur. So we're going to watch them very closely. Then patients often require nasal or oral intubation if crowning, stridor, or dyspnea is present. We're not going to take any chances. We're going to intubate that patient. Of course, we want to promote ventilation. I'm not reading all of that, but you can pause and read it on your own. You're going to monitor for gas exchange. You're going to be looking at the partial pressure of oxygen. You're going to be looking at the CO2. You're going to be looking at the O2 sat. Oxygen therapy, you know they're going to be on oxygen. Drug therapy. Remember, when it comes to burns, in part 1, I showed this to you. Part 1, what we're concerned about the most. And I added one because number one is airway. I completely forgot about it, but airway, that's number one, right? We're concerned about airway, pulmonary edema. We're concerned about shock because of all the fluid that left the vascular space. We're concerned about fluid electrolyte imbalance, all of the electrolytes that were in the fluid that left the vascular space. We're concerned about pain and infection. Remember, guys, your skin is your first line of defense from pathogens getting into your body. If the person's burned, that skin has been compromised, right? Yeah. So with that being said, yes, we expect that patient to be on antibiotics because infection is a very high risk for the patient. And especially if they breathe in those noxious agents, you're not supposed to have those type of pathogens in your lungs. There's a chance the patient may get an infection of the lungs. What's that? Pneumonia. All right. When the patient's activity during mechanical ventilation severely compromises respiratory mechanics, it may be necessary to use a paralytic drug, such as, I'm not going to try to pronounce these drugs, but you see them, okay? These paralytic drugs remove all breathing control from the patient so they can't try to breathe over the vent, okay? From the patient, making mechanical ventilation easier. But look, these drugs do not prevent the patient from seeing and hearing or from experiencing fear, pain, and loss of control. So guys, they're all here. They're intubated. They're on drugs that cause them not to breathe over that vent, but they see everything that's happening. They hear everything that's happening. They feel that fear, but they just can't express themselves. This is very important for you guys to know. Any patients receiving neuromuscular blockade drugs must also receive drugs for sedation, analgesia, and anti-anxiety unless it's clinically contraindicated. Because of course they're going to be severely anxious and fearful, and they're going to feel pain. So that's important to know. Critical rescue. As required by the Joint Commission's National Patient Safety Goals, ensure that all alarms are operative on ventilators. Check patients who are receiving neuromuscular blockage frequently because they cannot call for help if they become extubated accidentally. So you have to keep an eye on them. Positioning and deep breathing can improve oxygenation. I talked to you guys about that. Turn, cough, deep breathe. If you know they're not intubated, make sure they're sitting up. Rapid infusion of IV fluids. Again, we're going to be giving those IV fluids hard and fast. I'm not reading all of that, but you know, guys can pause this, read it on your own. Resuscitation involves hourly infusion volumes that are great in excess. Remember, I told you we are giving those fluids hard and fast. It is greatly in excess of 125 milliliters to 150 milliliters per hour. Okay, guys, I'm going to stop here. In part 3, we're going to go over, let me make this a little bit bigger for you. In part 3, we're going to go over the fluid resuscitation of the burn patient. That's where we're going to start. Guys, thank you. If you made it to the end of this video, please don't forget to like this video. Please don't forget to comment, help my algorithm going. Comment on the algorithm, comment on the video, guys. It really helps my algorithm. Let me know what you thought about this video, what you would like to see more of. Don't forget, on Sundays, every Sunday at 1 p.m. Eastern Standard Time, a video is released where I go over test questions and how to answer those questions, how to eliminate wrong answer choices. Right? And don't forget, I have audio lessons available for you on my website, nexusnursinginstitute.com. Thank you for watching this video, and you guys will see me on the next video.